Good evening, everyone. My name is Jennifer Stratton, and I'd like to welcome you to tonight's program. This is the final or last webinar of the CanIBD webinar series for the season, and we're so thrilled that you could spend this lovely, well, here anyway, lovely evening with us. Next slide, please. Tonight we have an awesome program set up for all of you. I'd like to welcome our guest speaker, Dr. Neelesh Shandy, and I'll go through his credentials in a moment, but I just also wanted to take a quick moment for a warm welcome to our AbbVie sponsors for tonight's program. We always are very appreciative of all of your support for IBD nursing in Canada. Next slide. I just wanted to remind you that CanIBD is always trying to stay on top of IBD nursing in Canada, and these are ways that you can stay in the loop and find out what we're up to. We have our website. You can also email us, find us on Twitter, as well as sign up for our monthly newsletter that gives you all the updates on CanIBD and our programs. Next slide. So I'd like to just take a moment to welcome our guest speaker for tonight. I'd like to welcome Dr. Shandy, who is currently a professor of medicine and gastroenterology at Western University. He's informed me tonight that he is moving on to a new endeavor very soon. He will be opening the Southwestern Ontario IBD clinic. And tonight, I'd like to welcome you, and I hope you appreciate all of his insights and knowledge and experience in IBD. If you have any questions, we kindly ask that you place them in the Q&A box at the bottom of your screen, and we'll be taking brief moments to answer any questions that you may have. Thank you, and welcome, Dr. Shandy.
All right, thank you for that kind introduction. And yes, I'm moving on from my hospital-based practice, and I'm going to open up my own Southwestern Ontario IBD clinic. I'm not going to steal anybody's patients. We got lots of patients to go around, but certainly looking forward to getting to work with other people outside of London Health Sciences Center. So it's going to be exciting. So thanks everybody for joining tonight. Thanks AbbVie for sponsoring. Thanks Jen for introducing me. So tonight we're going to look at the 3 W's, although we're going to get a cover 2 of the W's. We'll get to that in a moment, reflecting on gray areas in IBD treatment decisions. I don't think you need to see this. You're probably all very familiar. So I didn't actually make the slide kit. So these are the fine gentlemen that made the kit. So if you have any complaints, you can direct them to your preferred one of those 3. And there's their disclosures and some more disclaimers. And I have a few disclosures myself. All right, so here are the learning objectives that we're going to be looking at tonight. First of all, we're going to reflect on some key measurements that we use when we're supporting early treatment optimization and using that treat to target process that I think everybody's quite keen on and quite familiar with. We're going to consider other factors that might come into play when we're choosing treatments, making treatment changes. And this goes into inducing somebody into remission, maintaining their remission, prevention of complications. And then we'll have some time for some questions and maybe get some insight from some of you on what kind of thresholds and what kinds of other pieces of information come into play when we're fine-tuning patients and really trying to optimize their long-term outlook with their Crohn's and their ulcerative colitis. So this is kind of a slide that if you're doing an AbbVie talk, and I was fortunate to sort of get on the roadshow a few years ago in the pre-COVID era. This is I think a study that's really changed our practice, and it really changed it a lot, particularly in the early COVID days when we didn't have access to a lot of things other than a phone call and maybe a stool calprotection, which the patient did at home, and at the odd time maybe a blood test like a CRP. We didn't have access to colonoscopies. We didn't have access to in-person physical examinations. We didn't have access to a lot of radiologic tests, and it was really fortunate, I think, that COM came out when it did, because it really impacted the way I managed patients, and I made major treatment decisions on patients strictly with a phone call in a fecal calprotection, for example. So just to remind you, these are the key outcomes of the COM study, and there were 2 arms in this study. One was the clinical management arm, and one was the tight control arm, which was basically the exact same, except adding in a stool calprotectin with a cutoff of 250 and a fecal cal with a cutoff of, a CRP with a cutoff of 5. So if the patients were above those numbers, they would escalate their Humira. If the patients were below those numbers and they also had clinical remission, they wouldn't escalate their Humira. And you can see that in the end, tight control won out hands down over clinical management. So whether you look at steroid-free remission, deep remission, biologic remission, mucosal healing, whichever way you shake it, adding a calprotectin, adding a CRP really optimizes your treatment for patients with Crohn's disease. And then also really importantly, achieving remission changes the long-term outlook. And really that's, I think, a really important goal of treatment. You get the patient into remission, that's great, they're doing well at year 1, but you have to keep them well over years 2, 3, and so forth. So you can see in the graph on the right side of the screen, patients who achieve deep remission were much less likely to have a disease flare-up or a complication compared to patients that didn't achieve deep remission. And this is something that we discussed with patients, that really hitting them early with the right treatment, trying to achieve that 1-year target, does change their long-term outlook. And patients really don't like surgery, patients don't like steroids, patients don't like going to the emergency room. So these are the kinds of outcomes that I discuss with patients that we might impact by giving the proper treatment early in the course of disease. This is another really good slide, I think. So STRIDE 1 came out about 5 years ago. STRIDE 2, and I use this quite a bit in the clinic when I'm explaining to the trainees how we follow a patient with IBD, and this doesn't really matter if it's Crohn's or UC to any great degree. So if we start at the left of the graph, we have a patient who's got active IBD. We choose their initial therapy according to what we think their risk is of developing a complication. And there are identifiable risk factors for a bad outcome for both diseases. In patients with milder diseases, sometimes you can get by with milder treatments early in the course of disease, and patients who are at a much higher risk of complications or have lots of extraintestinal features sometimes need more aggressive treatment. So early short-term treatment, really you're trying to get a symptomatic response. You want the patients to start to feel better so they can return to their day-to-day activities, go to work, go to school, these kinds of things. Later on, and we're sort of into a few months down the road now, we're looking at symptomatic remission. We're looking at normalization of CRP. Steroids can normalize the CRP pretty quick. So that is a way to at least get some biomarker improvement. Later on, as you're approaching, 6, 9 months, we're trying to push our calprotectin now down to an acceptable range. It used to be that the calprotectin magic number, but certainly based on the COM study, was 250. I think in your own practice, you might have a patient who's got bad colitis and their calprotectin might be 10,000. So if you can get their 10,000 down to 600, that probably is in the acceptable range. So this magic number of 250 is a little bit of a soft number now, but it is, a target that you're looking for. And then after the first year of treatment, once you've now got them into remission, you're really looking at proving endoscopic healing. You're looking at normalization, the quality of life, and in long term, you want to prevent disability. So these are really long-term targets that we're looking for. And then on the far right, this is something that's probably coming because Crohn's disease is a transmural disease and not strictly a superficial mucosal disease. Maybe transmural healing as measured on a radiologic test might actually be an important outcome, and even more important, say, than healing seen at colonoscopy. So this is just a nice way, and in a way that patients really can understand what they might expect over the course of the first year and beyond when they're now diagnosed with Crohn's disease. But as I say, this also can apply to ulcerative colitis. So we're going to look off the menu here, and you can go to restaurants, so you can actually have a menu in front of you. We're going to look at early optimization, which is the first slide kit. We're going to skip loss of response and then move on to long-term monitoring of the stable patient. And that's a little bit of a problem these days, particularly with virtual care. Some patients seem to disappear. So you need a way to keep them engaged in the monitoring process. And as questions come up, feel free to put them in the Q&A. If it's a pressing issue, Jen, you can certainly feel free to interrupt. But if it's something that can wait until maybe the end of each section, that might be a good time for a stop and a little bit of a discussion. So here we go. Scenario 1, early optimization. So here's our patient. So he's a 30-year-old male. He's got moderate to severe ileal Crohn's disease. CRP is pretty high, 25. Fecal cal is exactly 1,000. We started adalimumab at a standard induction, standard maintenance dosing. After 3 months, so 12 weeks in, he's now in clinical remission. His CRP has normalized. His fecal cal has now improved. So we have to decide, I guess, has that improved to an acceptable range? But it still is maybe a little bit on the high side, so it's not 275. We decide to order an adalimumab trough level. It's exactly 10. So based on all that, and certainly based on the CALM study, because this patient has an elevated fecal calprotectin, he's not under the magic number of 250, that on its own is actually sufficient to consider escalating the dose. Now, we have one piece of information here, which was the trough level of 10. That piece of information was not available in the CALM study because trough levels were not used as one of the drivers of treatment changes. So things just to consider when you're having this early follow-up with a patient. So what are your treatment targets? Is it simply a symptomatic improvement? Are you starting to look at the biomarkers? Are you looking at if the patient still needs to be on steroids, if they were on steroids to begin with? What are the times to assess treatment response? I tend not to book a follow-up too early after initiating a biologic drug because I have no plans on changing my treatment unless the patient is very rapidly getting worse. So I typically, if I start a biologic, unless there's something I really need to assess, 6, 8 weeks after starting treatment, I don't book a follow-up till about 3 or 4 months because I'm not going to make any changes to my plan until that point, unless the patient is really worsening in the meantime. And then you got to decide what is your threshold for change. In clinical trials, we're really trying to hit these firm targets: fecal cal, CRP, endoscopic healing. A lot of patients don't entirely hit all the targets. And, is 90% better good enough? Is 70% better good enough? And you have to look at the individual patient. You have to look perhaps at treatments the patient's already been on, and what are your options if the current treatment is not doing what you think it should do. So the threshold for change is sometimes a difficult decision, I guess, in certain circumstances. So we've seen this already. Just to remind you that tight control really changes the outcome for the patient. You can achieve all of the main targets and eventually go on to prevention of the complications of the disease. And deep remission, just to highlight it once more, really is the goal of therapy. That's at 1 year. Right now, we're talking about earlier on in the course of therapy. So this is another little more recent study. This is the SERENE CD. There also was a SERENE UC. And this basically looked initially at high dose Humira induction compared to standard dose Humira induction. And everybody was real hot on this, particularly for the UC study, because everybody thought that the high dose was going to do a lot better than the standard dose. Everybody was really surprised and perhaps disappointed to some degree, because the outcome after induction, pretty much for UC and Crohn's, was exactly the same. That the standard dose induction did just as well as the high dose induction. And I don't think people should be disappointed. It means that we've had the right dose all along, and the dose we're using is the correct dose. But what came out of it that's actually really interesting is actually what happened in the maintenance study. So the UC one, those results came out first, and I don't want to ruin it for you, but it turns out that weekly Humira is better than every other week Humira as maintenance for UC, and that's actually changed my practice. That's my standard dosing now. But let's look now at the Crohn's maintenance phase of the SERENE CD study. So you can look at the graph on the screen here, and you can see that there's 2 arms. So one is the clinically adjusted regimen. So that's adjusting the Humira dosing based on symptoms, the CDAI, basically, or using trough levels. And all of us love to order trough levels, and we think we know exactly how to interpret them, and you can fine tune them and order some more and check it again and play around with the dosing. But does that do better than the old-fashioned clinically adjusted regimen? So I guess to some people's surprise, it didn't really make much difference. So these are week 12 responders. This is a re-randomization of patients that had responded in the induction. So we've sort of selected out the winners, and then they're followed to the course of week 56. And you can see through week 12 to week 56, the clinically adjusted regimen versus the TDM regimen, black and yellow respectively, the outcomes were almost identical. Clinical remission, endoscopic response, endoscopic remission, deep remission, and then the steroid-free and clinical remission in patients taking steroids at baseline. So you can decide how you want to interpret that. Is our messing around with trough levels and doing all these adjustments and hassling patients to get blood tests done, really the right way to do it? Or simply, if the patient seems to be flaring up, just give them more of the medication, and that's all you need to do. So there are different ways I think you might want to interpret the results of this. I guess in the end, as long as the outcome is what you're looking for, and you can get there any way you want. When you look at the clinically adjusted regimen, the drivers of treatment change were CRP or CDAI. And in fact, although CDAI is important, we still want our patients to feel better. The CRP actually was an important driver of treatment change. And I think even a more important driver than I would have actually expected. I find the CRP is helpful, but often is a little bit misleading, and some patients are not CRP producers and so forth. But in this, if the CRP was greater than 10 or the CDAI was greater than 220, that on its own would be enough to escalate treatment. You can see the treatments that patients ended up on over the course of week 12, week 14, all the way up to week 42. 72% of patients were still on every other week dosing, but 28% of patients were on weekly dosing. And in the TDM arm, the options for treatment escalation were a drug level less than 5, a CDAI greater than 20, or a CRP greater than 10. And this is the opposite. It was actually the drug level that was the most important predictor of treatment escalation. So over the course of 1 year in these patients, there was a slightly higher percentage of patients who ended up on weekly dosing compared to patients on every other week dose compared to the clinically adjusted arm that we saw on the previous slide. So I guess you can look at it either way you want. If you really want to measure some trough levels, then it's a good way to keep the patient engaged with their treatment and following up on some instruction. I think that's a great way to do it. If you're not that enthusiastic about measuring drug levels and optimizing your therapy just based on that, go with the more old-fashioned approach, which is a few symptoms and a CRP, and that might be sufficient for a lot of patients. So I think the verdict's still out there to some degree. This is a relatively recent sort of expert opinion from the American Journal of Gastro, published 2021, on what you should do with proactive TDMs. So that kind of reflects what we saw in the last study. Proactive TDMs, will it help your treatment, I guess? Will it help change the outcome? So item number 1, we've highlighted a few points here for interest's sake. Proactive TDM should be performed after induction for patients treated with anti-TNF therapy. 90% of experts said yes. Now, you always wonder what they would do with that result, but they said that you should be performing a proactive TDM. I think what's important is maybe the second one that they've highlighted here. Proactive TDM is most important in more severely active patients and in patients who have higher drug clearance. Now, you don't always know ahead of time who might have higher drug clearance. The only way you know is by measuring the level. But I agree with that one, I think, to some degree. Someone who's got more severe disease, that's the kind of patient you probably would consider pushing your treatment a little bit earlier in the course of therapy. And then the final one that we've highlighted here, proactive TDM for optimizing anti-TNF monotherapy, is better than unoptimized anti-TNF monotherapy. And I guess, just looking at the words they've used, if you're calling it optimized versus unoptimized, optimized wins out because it's a much more positive word to use, I guess, when you're treating your patients. So can you predict early in the course of treatment who is going to either lose response to treatment or develop antibodies against the drug? And this is a chicken and egg kind of thing. But for both infliximab and adalimumab, if you look at the graph here, patients who were in the first quartile of the drug level, so that's the red line, compared to patients in the second quartile in green, the third quartile in blue, and the fourth in purple. The patients who had lower quartiles for drug levels for both infliximab and adalimumab were much more likely to develop antibodies over the course of therapy. Now, was it the high drug level that prevented antibodies, or is it perhaps the fact that the patient was more immunogenic and therefore had a low drug level, but also therefore was more likely to get antibodies? We can't really answer that from this. But if you do want to predict in your own individual patient who's at risk of forming antibodies, an early drug level taken at week 14 can be quite predictive. Now, whether you're going to act on that, maybe add an immune suppressive agent, maybe do an escalation for this reason, that's something you have to decide based on the result and based on your individual patient. But it is kind of interesting that this is a nice way to be able to predict who might not get such a long maintained response to their treatment, and that applies to both anti-TNF drugs. So here's just a few tips just to kind of summarize where we've got to at this point. And I've been talking quite a bit. I guess that's a webinar. I'm the only one supposed to be talking right now. So you're going to assess patients clinically. Certainly, as treating clinicians, we want patients to feel better. I think that's one of our primary jobs. But we also really want to continue to monitor. So monitor them with non-invasive biomarkers, fecal cal in a CRP. At 3 months, I would only do it earlier, as I say, if the patient's getting worse. I wouldn't do it just as a routine at week 6, week 8, something like that. If you do have elevated biomarkers, you can immediately dose escalate, and that probably is what I do. Although I often will order a trough level just out of interest, but unless the trough level is way out of whack, I would just empirically dose escalate, even without knowing what that number is. And then, as I say, if patients have severe disease and they're at imminent risk of complications, ER visits, and so forth, that's the only kind of patient that really you should be making an earlier assessment on. And sometimes that requires some steroid medication or some nutritional support or something. So sometimes the patients don't follow the exact course of events that we would hope. So there are patients who remain symptomatic at week 8 with elevated biomarker, a trough level that's not ideal. There are patients who call the office because they're still symptomatic at week 4 and they heard that this drug works so fast. Why are they still having so much diarrhea and pain, and their calprotectin's even higher and their trough level is not that great either. So you have to decide, what are your backup plans in the event that things don't go as you predicted and then perhaps as you've laid out for the patient, in encouraging them to participate in your treatment plan. So there are actually ways to kind of know what will happen to the patient. And although this is not 100% predictive, and even at the best of times, none of these treatments are 100% effective, there are ways to get an idea about who actually is going to do well with the treatment and perhaps who's not going to do so well with the treatment. So this is with infliximab, and you can look at your infliximab trough levels early in the course of therapy, week 2 on the left, week 6 on the right. And if you have high numbers, and you can see the numbers they have here, 23.1 at week 2 and 10 at week 6, high numbers for your infliximab trough levels correlate quite well with mucosal healing at week 12. And again, this is a chicken and egg. Is it that the high level has led to healing, or is that the early healing has led to the high level? You don't know that based on this. But again, this is a nice way to at least predict in your own practice which of your infliximab patients are more or less likely to be doing well, perhaps at that early follow-up at week 12. And then similarly, you can also use in your adalimumab patients their early drug levels, and I'll highlight the graph actually on the right, which is a more important one. Patients who have high drug levels at week 4, 12.8, compared to patients who have lower drug levels at week 4, 8.4, are less likely, the high drug level patients are less likely to form anti-drug antibodies at week 12. So we have lots of options to order trough levels. They can be used to predict the outcome for the patients. The hard part sometimes is actually trying to know what to do with a level if it's not in the range that you would hope for that particular patient. This is a recent study, and this was a proactive adalimumab trough measurement pediatric study. So if you do adults only, you have to decide, does this apply to your adult population? But you can see that patients who had a proactive TDM, and they only used a target of 5, were more likely to be in remission and less likely to have a disease exacerbation compared to patients who had a reactive TDM. So perhaps at least in pediatric patients, an early trough level, escalating the dose based on that trough level. They don't like to use steroids in kids. They don't like to use immunosuppressive agents in kids. So maybe this is actually a good way to really optimize and minimize exposure to more toxic therapies, at least in pediatric patients with Crohn's disease. We don't know if this is entirely applicable to adult patients, but it does make sense, I think, to some degree that in the right patients, a proactive TDM really could influence the outcome for that patient. So week 4 really is an early time point, but there are, I think, some considerations that you can consider. It's not necessary for all patients, but patients who have a high inflammatory load or severe disease, low drug levels, and I'll throw in there perhaps multiple biologic failures where you're kind of running out of options. Early assessment, trough levels, and maybe even early dose adjustment might be the way to go. So we're not just going to talk about anti-TNF drugs. Of course, there are some other agents that we need to have some consideration on what to do. So what do you do if the patient is on one of these other drugs? Can we apply the same rules, I guess? And I think the short answer probably is yes. This is kind of a complex slide. I'm not certain if I entirely agree with it, but it did come out as part of the STRIDE-2 guidelines. And it is meant to basically tell you how many weeks it takes for different outcomes to occur. So if you look at the top, for example, just to run you through and get an understanding, patients who are on oral steroids, you'd expect a clinical response in the white at about 2 weeks, clinical remission at 4 weeks, normalization of CRP and ESR at 5, decrease of fecal calprotectin at 8, and then endoscopic healing at week 13. I'm not certain that oral steroids and exclusive enteral nutrition work that fast and necessarily work better than an anti-TNF drug, which is kind of suggested by the graph. But this is just, I think, a way to get a sort of a feeling about how long certain treatments might take. And if you look at this, the bottom graphs, some of the newer agents, vedolizumab and ustekinumab, this is kind of out there in the literature a little bit. Perhaps they do take a little bit longer to achieve some of the targets that you're looking for. So maybe, a week 4 assessment isn't really what you're looking for. Maybe you're looking more a week 8, 12, even 16 and beyond for some patients on these drugs. But this is just what was published in that STRIDE-2 guideline, and take it for what it's worth. Probably the most important thing here is that the thiopurines and methotrexate probably have very minimal benefit, particularly the thiopurines, I think. So if you are going to look at vedolizumab, this is a little bit of a complicated slide. If you measure a week 6 dose, a trough level of less than 18.5 was associated with the need for drug optimization within 6 months. So a very early induction trough that is low does, to some degree, predict that you may be changing therapy fairly early on in the course within the first 6 months. And then patients who need an optimization at week 10, and I actually do this quite a bit in my own practice, I find that patients are a bit anxious about taking 3 doses in the first 6 weeks and then having to wait 8 weeks for their next dose. So in my own practice, actually quite a bit, I offer the patient a week 10 dose if they're not fully, sort of feeling that they're improved with the first 3 induction doses. But in these patients, a trough level of less than 19 measured at week 6. So these are patients who got a week 10 dose but had a trough level measured at week 6. It does associate with an improvement over the course of time, that they have achievement of a secondary response. So the way to, I guess, understand this is that if you have a patient who you're going to use vedolizumab, if they have bad disease and you think they're at risk of having a bad outcome, measure that week 6 dose and probably offer a week 10 dose if the level is too low. And too low means basically less than 19. And that might improve your outcome, at least over the first 6 months. They know they've got IV and they've got subcutaneous. So some of this is not entirely certain, But one extra dose of vedolizumab, I don't think is going to hurt anybody. And even if the patient makes the patient feel a little bit more comfortable that they don't have to go 8 weeks in between doses, I think that's okay. Ustekinumab is a little bit more difficult because you get a single IV dose to start, and then you don't have your next dose for 8 weeks anyway. So you don't really have a lot of opportunity for early trough levels and changing your dose. You basically have to wait anyway. So I think in IBD, most of us use 8-week dosing regardless. I've used a little bit of 12-week dosing in patients that were trying to minimize their overall immune suppression. Didn't seem to make much difference over the course of the initial therapy, but it does give you actually a few more options for escalation, because then you can go from 12 to 8 to 6 to 4, whatever you need. So I sometimes actually use the 12-week dose to my advantage because it gives me a few more options in the future. So this is kind of another, I think, an interesting recent study. This is the Seaview study. So this was this Stelara versus Humira, and there was all patients got an active biologic drug. So it was very easy to recruit patients, I think, into the study because you could get, a really good treatment regardless. It was completely standard dosing Stelara, standard dosing Humira, no options for dose escalation. There was a placebo for the other drug, so it was actually a placebo-controlled trial. All patients got one or the other of the active medication. And I think much to some people's surprise, depending on which company I guess you're working for, the outcomes were basically identical. The primary endpoint of clinical remission at week 52, you can see there, you can sort of follow the patients on the right. Over the course of therapy, no drug was better in early, no drug was better in late, and really the lines were pretty much parallel. Corticosteroid-free remission, patient-reported outcome remission, endoscopic remission. The numbers are so close that there absolutely was no difference to speak of between the two different medications. But I think the thing to really highlight here is that there was no option for dose escalation. And in my own practice, I think escalating adalimumab probably works better than escalating Stelara. So if you had an option for escalation, maybe the adalimumab number is going to be a little bit higher, and maybe in the end that would have given a better result. We don't know that from this study. This is my own speculation. So there's little data for early optimization, particularly for ustekinumab, for Stelara. You don't really have a lot of options for escalation anyway. But as we highlighted earlier, in select vedolizumab patients, consider a week 10 dose, particularly those patients who have an increased inflammatory load. So that's the end of section 1. That's actually the long section. I see that there are a few questions I think that we put into the chat box. Jen, did you want to bring up any points for discussion before we move on to part 2?
Yeah, no, actually, Usha Chohan from Hamilton, she has a couple questions for you. Firstly, she's asking, do you routinely monitor trough levels on all your new start patients?
That's so a proactive trough level, and we're talking about all new starts. So definitely not for ustekinumab and vedolizumab. I would say I order them out of interest for my adalimumab patients. And one of the reasons I like to order it is because it forces the patient to go get a blood test. I'm actually probably more interested in their CRP. And if you order the trough level through AbbVie Cares, the patient is way more likely to get their blood test done compared to if you just send the lab rec to the patient and expect that they'd go to their lab downtown. So it is a way to get one piece of information that you sort of put in your back pocket, and another piece of information, which is the CRP, which you put in your front pocket. So I would say yes for adalimumab, no routinely for infliximab, because I know exactly when the patient's going back for their next infusion, and I know exactly when I can order a trough level in those patients, because you're kind of controlling what they're doing. The patients on sub-Q are sometimes not quite as easy to control.
Mm-hmm, mm-hmm. She also is asking, when do you, and this I think is a classic question we get quite a bit, is when do you measure fecal calprotectin routinely on your new patients? So
yeah, so this is basically, as directed by the biologic drug companies, I guess, to some degree, since they're the ones paying for it. So if they're on Humira, or even I guess all the biosimilars now, I routinely order it at 3-month intervals. Now, again, patients don't usually send in the kits at 3-month intervals. So even if they only have 50% compliance, at least you're getting 2 of them per year. For the other companies, their standard offering is at 6-month intervals. So I'm happy to get those results as well. And I've certainly found out over the course of many years, you probably guys get these as well, that you're probably more likely to get a non-compliant notification from Dynacare than to get a fecal cal result for Dynacare.
Okay. And her last question was, when you commented on the use of an extra dose of Veto at about 10 weeks, do you need to get special permission for that? Is that considered compassionate? What do you
Yeah,
usually do
I
with
think it's
that?
probably compassion. I think, certainly government will not pay for an extra dose. Some private insurers might, but probably most of those week 10 doses are compassionate. I've had zero difficulty getting that dose when I've needed it.
No, I agree. I've had the same situation, and they've been very agreeable to providing that. All of the companies, actually, I haven't had any
Yeah.
trouble, so that's
I think
great.
there's so much competition between the companies. They don't want to do anything that might upset one of us.
Okay. I had a
Okay.
quick question just
Sure, go ahead.
around anti-drug antibodies. So, and I've asked this question before, but my brain doesn't seem to retain it. At what level do you attempt to overcome those antibodies with just increasing the dose of the drug? And at what point do you give up and say it's time to move on?
Yeah, that's a great question. I guess each drug is different. But for example, if you're going to use, say, infliximab, which might be the classic example of anti-drug antibodies, if you have levels, 5, 10, 15, 20, somewhere in that range, I think there's a high chance you can overcome that and buy the patient, many, many more infusions and perhaps years of treatment. When you're up to 50, 75, 100 or above, I think the likelihood of success is a lot lower. So I don't have an absolute number. It really depends on how well they're doing on that medication and what your other options are. If it's your first treatment and you got lots of other great options, you don't want to mess around too long and put the patient at risk of perhaps even having an infusion reaction, just switching to something else. If you have no other options, you really have to, optimize and save what you can, perhaps to buy some time until some newer agents become available, even later this year. And that's the kind of patient that maybe you'll push your dose higher, add some azathioprine or add some methotrexate, at least try to buy the patient a couple more infusions before you have to call it off. So as I say, I don't have an exact number, but those are kind of the ranges that I'm in favor of saving versus in favor of moving on to something else.
Great. Thank you very much. Okay, I think that's all the questions for now.
Okay. So we've got our patient, we get him on whatever treatment, let's just say adalimumab, for example. He's doing great. And that's where it gets a bit more difficult, as I mentioned earlier, with virtual care. Sometimes it's hard to rein in patients, and you book an appointment and they don't answer the phone, or they're doing a video call. Patients often have excuses that they still don't want to come into the hospital to see you, although perhaps that's not a great excuse anymore. But really keeping them under remission is a really, really important goal, because it's a chronic disease. So our guy's changed his appearance a little bit over the course of his first year, but now he's a 35-year-old male. He's got ileoclonic disease, Crohn's disease. He's had for 4 years. So that diagnosis, he had 30 centimeters of ileal involvement and also some disease at the right colon. So it's a pretty good chunk of disease. Initially received some prednisone, azathioprine. He tried to taper his steroids. He had symptomatic recurrence. And this is basically where he came into initially. So baseline investigations, he's sort of borderline on the anemic side. Platelets are a little bit elevated. CRP is 22. Albumin's low at 32. And then the fecal cal, primarily with small bowel disease, isn't all that high. It's 675, but certainly higher than you'd like to see in that. So he has some baseline investigations. His ileum actually looks pretty bad. He also has an ultrasound. If you have access to ultrasound, I think this is a nice way to be able to follow patients radiologically without having to expose them to radiation with CT scans. And of course, access to MRIs is not always so easy when you need it. But he has deep serpiginous. He's got broad-based ulcers over 30 centimeters of his ileum. There's some luminal narrowing. He's got a little bit of colonic disease, not as deep in the colon. And then, of course, at least in clinical trials, we like to measure scores like the SES-CD. A lot of people in clinical practice don't necessarily report those scores, but we often report the kinds of elements that would be found in the score. So he's still smiling because now he gets onto adalimumab. He goes on to standard induction every other week dosing. He gets into symptomatic remission in 6 weeks. He tapers his steroids and remains on adalimumab, 40 milligrams every other week as monotherapy. And he thinks that's the end of the story because he's doing well. So 12 months in, he's just doing great. His borderline anemia has now resolved. His platelet count, which was elevated as a sign of inflammation, is now normal. CRP, which was elevated, is now normal. His fecal cal, which was previously elevated, is now well within the acceptable range. And this is at 12 months. And then you do a follow-up scope, and magically, it's all healed up. So he's still smiling. This is how he looks on his video call, I guess. He just does the same picture. So he's seen every 6 months in year 2. He's actually quite compliant with getting stuff done, blood work, CBC, CRP, fecal calprotectin, and so forth. You're fortunate to have access to ultrasounds. We got some further ultrasounds along the way, and everything's just going great. We saw this slide earlier, so just remember our long-term targets, endoscopic healing, so we've hit that. Normalized quality of life, probably, he's very smiley. Absence of disability, so far so good. So these are really the long-term targets, and we've hit them all. But, you know, the story doesn't end at 1 year. Crohn's is not a one-year disease. Crohn's is a lifetime disease. So keeping that arrow, you know, I guess on the right side of the line is really what we're still trying to get. So it's great to have a compliant patient because you get numbers over time. And sometimes a single aberrant CRP, certainly a single aberrant calprotectin, doesn't always tell the whole story. But monitoring the patient over time, you can see 12 months in, his CRP and his fecal cal are pretty good. 18 months are pretty good. But now at 24 months, CRP has gone up to 8.1. His fecal cal has gone up to 275. You can see the trend is going in the wrong direction. Highlight once more, I'm required, I think, by AbbVie that if I do a talk on their behalf, I have to show the CALM slide 14 times. So the primary endpoint of the CALM study, we didn't really highlight this earlier, is that using the fecal cal, the cutoff of 250, using the CRP with a cutoff of 5, compared to the routine clinical management, which is basically a CDAI or a need for steroid, patient in the tight control group had a 45.9% chance of achieving the primary endpoint compared to 30.3% chance in the clinical management group, with the primary endpoint being mucosal healing with absence of deep ulcers at week 48. So there was a 50% higher chance, 50% greater than 30 is 45, so 50% higher chance of achieving full mucosal healing simply by adding in the CRP and adding in a calprotectin as part of your routine monitoring tool done at 3-month intervals. And they're very easy tests to do. They're not invasive. And the way I try to sell it to the patients, particularly the calprotectin, because they don't like to do the poop and smear and send it back, or poop and take a picture on your cell phone. The way I like to sell it to their patients, that might get them out of a colonoscopy. And sometimes that's adequate to convince somebody that's actually an important test that you're looking for the results. And what actually were the real key targets? It's actually both. So it's not strictly a CRP, it's not strictly a fecal cal. Really, if you achieve both of those targets, CRP less than 5 and a calprotectin less than 250, you have an 80% chance of achieving deep remission, a deep endoscopic remission at 1 year. So although perhaps in my own practice, I pay a little bit more attention to the calprotectin, really, I think both numbers are very important. We talked earlier about using a cutoff of 10, but the number 5 is what's used in the CALM study. We saw that already, that if you achieve remission, you can change the outcome. That's not the only study that's shown this. So this is not a new concept. This dates back to the mid-2000s. Patients who achieve mucosal healing are way more likely to achieve long-term clinical remission. This is on the top graph, and are way more likely to achieve surgery free disease. And this is at the bottom graph. It actually does make sense to us. It certainly does make sense to patients that if you can heal their bowel, they're much more likely to have a good outcome in the long run. So I think that's probably the real key to this second part of the talk, that you spend all this time and all this work and this effort and follow-ups and blood tests and calprotections in the first year to get the patient just as good as you can get them. You do perhaps your follow-up colonoscopy, maybe a radiologic test to prove that they've now achieved that target, but you have to stay on top of it. You have to continue to follow, you have to continue to monitor, adjust your treatments if necessary, because if you don't, you'll eventually lose response. And it's okay these days because we have lots of other treatment options. There are still patients that run through treatments pretty quick. And because Crohn's is really a long-term disease, engaging them into that management plan and really plan to adapt, that if something is not as you would like it for your patient, then you have to kind of have your backup plan ready to go in place and make sure that the patient understands that it's just not set it and forget it once they're doing well. So we'll stop there, and we have a few more minutes for some questions and some discussion. I'll actually stop the screen share, so maybe we can get Jen even on the screen here for the discussion.
Great. Well, thank you very, very much. So just a reminder to everyone, if you could please put your questions either in the Q&A, or it looks like some have put them in the chat. That would be great. Just the one comment, when you're talking about long-term management, I'm guessing you're more persuasive than I am, but I've been struggling lately with people feeling great at year 3, year 4, and not wanting to continue therapy. They feel that they've kind of beat this disease and they'd like to take a break. How do you respond to that when your patients present that?
Yeah, that's a hot topic. So de-escalating therapy in the right patient. So the first thing I discuss with the patient is I remind them how bad they were when they first started. And sometimes they've done so well for so many years, they kind of forgot that they were just about ready to have an operation. I sometimes put it into the perspective of other diseases, that if you're treating diabetes or blood pressure and they're doing great on their insulin or they're doing great on their blood pressure pills, if you stop the insulin, all of a sudden their blood sugar is going to go out of control. So with many chronic diseases, the treatments work best when you're on them. So I try to remind them of that. But there are cases where patients really want to be off treatment. Certainly these days we try to minimize and perhaps eliminate immune suppressive drugs. And in the kind of patient that's keen on that and is engaged in the process, and isn't just someone that kind of disappears and you haven't heard from them until they flare up 3 years later, the way that I do it is I like to have proven remission for an extended period of time. And to me, proven remission, certainly symptomatic, certainly biomarkers, and then really endoscopic remission as well. And an extended period of time probably is at least a couple of years. And then you also want to make sure the patient is engaged with follow-up. So follow-up, again, usually requires some clinical visits. It requires some monitoring of a calprotectin and some monitoring of a CRP. And I almost always will do another scope about a year, maybe 2 years after stopping or reducing a treatment, just to confirm that the disease is not starting to flare back up. And there are lots of patients that if they flare up a little bit, it's not the end of the world, but most patients will respond to the same treatment again. They have to be aware that it might not work and they might develop antibodies. But in select patients where there are, I guess, backup plans, meaning they haven't failed multiple treatments already, it's not a completely unreasonable idea to look at de-escalating and even eliminating therapy with appropriate follow-up, as long as the patient understands that things could go bad, and if things go really bad, they could be looking at complications, even surgery.
Okay. I guess I'm just very apprehensive of that because it has gone bad for some of our patients. And so I try my best to avoid that, but there's just some people who are very keen to proceed. And
yeah, and we've got lots of patients that, they've had Crohn's for 30 years and they had lots of steroids in the early course of disease, and they've been on a 5-ASA for 15 years and they're doing great. So I think there are patients, there are cases of Crohn's disease that the inflammation just subsides over time, and although the patients, they never look all that healthy, the disease just doesn't seem to progress much either. So it's such a variable disease that, there are patients that actually do well, even if we think that they might not.
Okay. I see Usha has a question here, and I actually wondered, Usha, if you would like to take your mic off and ask the question yourself, just because I'm not 100% clear on what you're asking, and maybe you could clarify that for us.
So my question is your threshold. So if the first biologic isn't working very well, and you still got that borderline FCAL that hasn't really gone down, what is your threshold for keeping that patient on that first biologic before switching to another?
Yeah, that's another great question. So if you think about it based on clinical trials, where the primary endpoint is deep remission or mucosal healing, a very hard endpoint, and you're following that, I guess then you have to call it off in a patient who doesn't achieve that endpoint. In real practice, there are lots of patients that are good, but they're not great, and picking the patient that should stop a treatment that's working, even if it's not working 100%, and then putting them on something else where maybe the response rate's even lower, that's a really, really tough decision. So I don't really have a firm answer on that. That's one where I think you have to really reach common ground with the patient. How good is good enough? Is it symptomatic remission? Is it biomarkers? I still really like mucosal healing, especially for UC patients, because the risk of colon cancer, for example, in uncontrolled inflammation is certainly a lot higher. But the good news these days is we have so many treatment options, and there's another one that just became available in the last few weeks for UC, ozanimod, and then we've got some other new treatments coming up in the fall. You don't have to push a drug for months and months and months. If it's not working, you can start to think about what your backup plan is. So I gave you no clear answer on that because there isn't a clear answer.
Did that help, Usha?
Yes, thank you.
Yeah, it can justify that you've always made the right decision.
Ozanimod? Sorry, have you prescribed ozanimod, and how can
No,
you
I still
get
have
that?
to. I've got my EMR set up to prescribe it, and all the forms and documents and the ECGs and the blood pressure measurements and the cardiology consults, and I just I got to find my stethoscope.
I have a patient who's been asking for it for the past year. And in fact, I just got an email in the last couple of weeks. Usha, my pharmacy says it's available. When can I get it?
Yeah, you can get it tomorrow.
Yeah, okay. Well, I have to work that one out.
Yeah.
with
so
the
it
GI
is available.
because
I think
it's complicated.
Yeah, it's a good treatment. I think it's not going to take off too quick, too early. I think just because of the inconvenience of having to do some of the cardiac stuff. But I think if you pick the patients who are at low risk of cardiac complications, the ozanimod patient support program actually is going to do most of that stuff for you. So although I'm sort of joking that I'm not a cardiologist, they do all that for you. They do the ECG and the monitoring for 6 hours and whatever else might need to be done. So I think it will be a good option for select patients. And they have lots of documents and brochures to help you pick which patients are suitable for ozanimod and which patients are not suitable for ozanimod. So I haven't yet used it, but it is something that I plan on using in the right type of patient.
Thank you.
Earlier tonight, you were talking about dose optimization. And is there any unusual practices that you've had? I know that people should cover their ears, but have you ever dose optimized higher than what is typically recommended?
Yeah, I mean, if I'm choosing to optimize strictly based on the trough level, then there should be no limit to how much drug you give. So although the standard escalation might be 40 milligrams a week, I've got a lot of patients on 80 milligrams a week. I've got some patients on 120. I've got even one patient on 160 milligrams a week. And she's a very compliant patient, and she comes for visits, and I'm comfortable that she's actually taking it properly, and she just keeps running very low trough levels. And one thing we have access to in London is clinical pharmacology consultation, where through it's basically a research protocol, but one of the tests that they offer us is a genetic test to predict the likelihood that a patient will develop antibodies against an anti-TNF drug. So all new anti-TNF patients, we routinely do this, or if we're going to consider stopping or de-escalating therapy, we routinely do this, or if someone seems to have levels that don't jive with what we think they should have, based on the clinical situation, we order that level as well. And we've got lots of patients who we can, optimize their therapy because they're at high risk of antibodies, or perhaps because they're at low risk of antibodies and would do well with monotherapy. So it's not a standard offering across Canada. I think there's only a couple labs that do it in Canada, but it is something that we have access to here in London.
Excellent. Well, thank you very much. I don't see any other questions. If you have a quick question, get it in now because we're getting close to the end of tonight's program. I would like just to take a moment to thank, oh, wait, here's somebody. I do have someone. I missed them in the Q&A. Oh, I'm sorry, Irina. Irina Nestor has asked, talking about new drugs, do you have any clinical experience with the new JAK1 inhibitor, UPA, any clinical pearls?
Yeah, no clinical experience just yet. I have heard of people who are accessing it for UC patients because the patients have another disease that it actually can be helpful for, but I think that's very selective and has to be done in consultation with perhaps a different kind of specialist. But I'm certainly very excited that, about it. I think it works very early, within a day or two in some patients. It really does seem to have a lower risk of adverse events compared to tofacitinib. So I think the concerns that came up with the JAK group as a class probably are not applicable to UPA. But I think this is something that we'll probably get more data, particularly in IBD patients, pretty soon after its launch, because I think there are lots of people who are very keen to prescribe it, and it's certainly got lots of patients that would be appropriate for it.
I'm sure we'll be hearing more about that in the coming months. Great. Well, thank you very much, Dr. Shandy, for spending tonight with us. You've provided us with some excellent information and tips and pearls for us to take back to our practices. And I'd like to wish you all the best with your new professional endeavor. It sounds very exciting. And we hope to welcome you back to CanIBD once again in the future.
Excellent.
Before I wrap up, I'd just like to remind everyone that it's important for you to complete the survey at the end of the program. It's how we work to improve our programming for you. I also wanted to remind you that this will be the last webinar of the season, and we will welcome you all back in the fall for a continuation of our webinar program, as well as for the CanIBD National Conference will be held in person this year in November in Toronto in conjunction with the Meeting of the Minds program. So please go online and sign up. Spots really take up quickly. So if you haven't done so, get there quickly and get that done. And on behalf of CanIBD and our steering committee and everyone who's here tonight, we'd like to thank you again for participating, and we'll see you all again in the fall. Take care.